And now you can see it.
Okay. Yeah.
Yes,
Great.
it's okay. Okay. I can start. Yes. Dear friends, dear colleagues, allow me to inform you about thermographic and sonographic findings in patients with ankle and foot pain. Jo, ale nepohybuje sa mi to tu. Aha. For beginning, thermography shows the temperature distribution on the surface of the ankle joint and foot, as is an indicator of lesion severity, reparative and inflammatory processes. May also be the result of increased activity of adrenergic substances in autonomic nerve fibers. Sonographic images are generated by the reflection of ultrasonic waves at the point of impedance changes. Sonography can differentiate the examined structures, can identify the structure that is the source of the pain. For the beginning, only anatomical minimum, articulatio talocruralis and foot is made up of 30 bones in total. 25 joints allow movement between bones. On the following pictures, you can see the basic anatomical structures, bones and joints on medial side, lateral side, dorsally, posteriorly, and plantarly. Joint strength is ensured by 26 ligaments. Movement in the joints is possible thanks to 9 tendons passing through the leg and 22 muscles of the leg. Smooth movement of tendons and ligaments allow 26 bursae. On these pictures, you can see tendons and bursae on the lateral side, medial side, dorsally, and plantarly. Vascular supply is provided by 3 arteries with branches. Joints and periarticular structures are innervated by 3 nerves with branches. On these pictures, you can see neurovascular structures dorsally, plantarly, laterally, and medially. Pain generator may appear as a consequence, injuries or diseases of any of the anatomical structures of the ankle and foot. Our study is a retrospective study for the period January 2010 to July 2025. We selected only those patients who were admitted to our department for ankle and foot pain and who underwent a sonographic and thermographic examination as well as one of the other imaging methods, X-ray, MRI, CT. All patients were examined clinically, myoskeletally, also biochemically, if required to establish a definitive diagnosis. The basic criterion for the evaluation of a thermographic image is the description of temperature deviations from the normal temperature pattern and absolute temperature parameters. The number of patients who filled this criteria was 569. Women 248 in age from 3 to 86 years, average age 48.5. Men 321 in age from 5 to 86 years, average age 44.3. According to the location of the findings, patients were admitted to this diagnosis: achylodynia 192, ankle joint 115, foot plantar 152, foot dorsal 44, 54, toes 56. The total number of positive sonographic findings was 803. On this diagram, you can see dividing the income diagnosis. Results: 56% of sonographic findings were findings of solid structure, osteophytes, calcifications, ossifications, gouty tophy. 19% were findings with liquid content, bursae, cysts, gangliomas, hydrops, edema, and others. 15% were tendinopathies and enthesopathies. 6% were injuries, as ruptures, fractures, abruptions, and total endoprosthesis. Others, as aseptic osteonecrosis, ulcerations, defects, grout pains, were 4%. On this graph, we can see dividing sonographic findings. 81% of thermographic findings has changed temperature activity. From that, 74% have increased temperature activity, 7% decreased temperature activity, and in 19% we found normal thermal pattern. On this graph, we can see dividing temperature findings. In the following part of my presentation, I would like to show you some examples of thermographic and sonographic findings in various parts of ankle joint and foot. I will start with posterior part of articulatio talocularis. On these pictures on X-ray and sonography, we can see supranumeral bone on the posterior part of ankle joint. It is ostrigonum, which is under the Achilles tendon. This ostrigonum could make pain in some cases. On thermography, in this painful case, we can see increased temperature activity on the site of ostrigonum. This is an example of feeling recessus articularis posterior lateri dextri. On MRI and on sonography, we can see feeling of this recessus posterior. And on thermography on this site, we can see increased temperature activity. Here we can see, distorsio articulatio talocularis with periosteal abruption of insertion ligamentum talofibulare on the part of malleus lateralis on X-ray and also on sonography. And on thermography, we can see increased temperature activity on the affected site. Distorsio articulatio talocularis lateri dextri, abruptio ligamentum talofibularis pars talaris. On this case, it is abruptio this ligament on the insertion on talar site. Here we can see some periosteal abruption. On the site of this injury on thermography, we see increased temperature activity. Distorsio articulatio talocularis lateri sinistri with abruptio tali anterioris. This abruptio we can see on X-ray and on sonography. And on thermography, we see increased temperature activity in the anterior part of articulatio talocularis with maximum of the site of the defect. Gautitophy in ankle joints. In the anterior part of articulatio talocularis under the tendon musculus tibialis anterior, in recessus anterior, we can see a huge amount of gautophy on both sides. And on thermography, we can also see on both sides in the anterior part of articulatio talocularis increased temperature activity. Here we can see aseptic osteonecrosis, tali on MRI and on sonography on the lateral part. Here we can see malleus lateralis. And on thermography on this side, when we comparing that with contralateral side, we can see increased temperature activity. Fractura malleoli lateralis lateri dextri. On X-ray and on sonography, we can see interrupted and fractured malleus lateralis. Thermographically, we can see increased temperature activity on the site of fracture. Total endoprosthesis, articulatio talocularis lateri sinistri. The total endoprosthesis we can see on X-ray but it seems like it should be normal. But in sonography, we can see calcificates and huge amount of filling in the anterior recessus. As a consequence of that, we can see on thermography increased temperature activity in the anterior part of articulatio talocularis, which is the complication of the total endoprosthesis. Hydrops articulatio talocularis lateris sinistri anterioris. In the anterior recessus of articulatio talocularis, we can see hydrops, hypogalmic filling under the tendon of extensors digiti and musculus tibialis anterior. And due to this, we can see increased temperature activity in the anterior part of articulatio talocularis. Lymphedema lateris sinistri, on sonography, we can see hypoechoic filling which divides the fedrobuli, but also increased and filled bursa in the anterior part of articulatio talocularis. And due to this, the temperature activity over the articulatio talocularis is increased. Growth pains. In this case, the finding, X-ray finding, X-ray sonographic finding over the growth place is normal, but this adolescent was in the period of huge growing, of accelerating growing. The metabolic activity of the growth plates was increased, and consequent of this is increased temperature activity over the growth plates. Following part is feet posteriorly, achillodynia, calcaneodynia. On these pictures, we can see on X-ray and on sonography, calcara calcanei dorsalis, but also ossificates in the structure of Achilles tendon, also with disruption of filaments of the tendon. And due to this, on thermography, we can see increased temperature activity on the site of insertion tendon, Achilles tendon. Calcara calcanei dorsalis, we see on X-ray and also on sonography, but the main problem is tendinopathy of the Achilles tendon. We can see enlargement of the insertion of Achilles tendon with disruption of some filaments of the tendon and the hypoechoic filling. That means that in the insertion are partial rupture. Due to this, we can see increased temperature activity at the site of insertion Achilles tendon. Bursa subachillea on the right side. On MRI and on sonography, we can see filled bursa subachillea, and on thermography on the site, on the affected site, is increased temperature activity. Gouty toffee intraachillary on the left side. X-ray is normal, but on sonography, we can see in the structure of Achilles tendon a huge amount of gouty toffee. These are these white flecks. And on thermography, due to this, is increased temperature activity in the distal part of Achilles tendon. Ruptura partialis tendoachillei lateri dextri. On sonography and also on MRI, we can see partial ruptured Achilles tendon in distal part. And on thermography, as a consequence of that, is increased temperature activity. Sutura tendoachillei lateri sinistri. This is example of healed ruptured tendoachillei with surgical intervention. But on MRI and also on sonography, we can see that the the healing isn't complete. Here we can see also stitches. And as a consequence of that, we can see increased temperature activity at the site of healed tendo Achillei. Another part, foot dorsally. Hydrops articulatio talonavicularis lateris sinistri. On X-ray, we can see widening of joint, and on sonography in the joint, we can see hypoechoic feeling, and on thermography on the site of injured place is increased temperature activity. Distorsio talonavicularis lateris sinistri. Here we can see also widening of the joint, but without hypoechoic feeling, but ruptured ligaments and capsula articularis. And as a consequence of that is increased temperature activity on the injured site. Aseptic osteonecrosis, ossis cuboidei on the right side. On the MRI, we can see aseptic osteonecrosis, ossis cuboidei, and some fragments on sonography, and thermographically on the site of aseptic osteonecrosis is increased temperature activity. Ossificates of tarsus bilaterally. On X-ray and on sonography, we can see these ossificates dorsally on the foot, on the both sides, which lead to the increased temperature activity over the ossificates in both foot. Ostibial externum on the left side. On X-ray and on sono, we can see ostibial externum, which is the supranumeral bone on the foot. This bone we cannot see always, but when it is, it could make problems. And as a consequence of irritation of this extranumeral bone is increased temperature activity on the affected site. Osperoneum on the right side, it is on the lateral side of the foot, also this extranumeral bone. We see it on X-ray, on sonography, and on the side of this extranumeral bone, osperoneum, is increased temperature activity on the painful leg. Ganglion on the left side, on the left foot. On sonography, we can see hypoechoic feeling, well-bodied ganglion, and at the site of the ganglion, we see increased temperature activity. Edema of the left foot. On sonography, we see hypoechoic feeling between the fedlobuli in supranormal part. And as a consequence of that, in this case, is increased temperature activity. In some cases, we sometimes found also decreased temperature activity in lymphedema. Not always is in lymphedema increased temperature activity. Fractura tuberositatis ossis metatarsi quinti lateris sinistri. On X-ray, we can see this fracture, and also on sonography. And as a consequence of that is increased temperature activity, the left foot. Foot plantarly, osteophyte ossification plantarly on the left side. On X-ray and also on sonography, we see calcar calcaneus plantaris, but on that calcar is also osteophyte, which is the main problem because it irritated plantar aponeurosis and lead increased temperature activity on the affected site and pain. of the affected foot. Ossificate in plantar aponeurosis on the left. On X-ray and also on sonography, we see ossificate in the structure of plantar aponeurosis, which is here. And as a consequence of this irritation is increased temperature activity on the affected foot. Surgical interruption of plantar aponeurosis on the left side. X-ray is normal, and on sonography we can see sharply incision, plantar aponeurosis, and due to this, the temperature on the affected site is increased. Here we can see ruptura partialis aponeurosis plantaris lateri dextri. Plantar aponeurosis on sonography is also interrupted, but it is not, the border of the interruption are not sharp, but blurred. It is due to ruptura or rupture partialis. And as a consequence of that is increased temperature activity on the plantar side of affected foot. Bursa above the plantar aponeurosis of the right side. On X-ray and on sonography, we can see calcar cancani plantaris, but it is not the main problem. The main problem is filling of the bursa over the plantar aponeurosis. Here we can see plantar aponeurosis, and over the plantar aponeurosis in plantar site is filled bursa, which lead to increased temperature activity and consequently the pain of the affected foot. Mucoid degeneration of the attachment of the plantar aponeurosis on the left side. Also, here is calcar calcani plantaris on X-ray and also on sonography, but the main problem is degeneration of insertion of plantar aponeurosis, which you can see here as enlargement and filling this mucoid foci. And as a consequence, increased temperature activity on thermography. Ossification under ossis navicularis plantarly on the right side. On X-ray and on the sonography, we can see ossificate in the plantar side of os navicularis. Above the ossificate is also hypoechoic feeling, and that leads to increased temperature activity in the plantar side of affected foot. Fractura calcanei lateri sinistri, it's in healing stage, but not complete healing. Here we can see X-ray and sonography of the fractured calcaneus. And in this stage of healing, the healing isn't complete, and because the temperature is still increased on thermography. Toes. Osteophyte under capitulum metatarsi primi lateri dextri on X-ray and also on sonography we can see ossificate under the capitulum metatarsi primi, and on the side of the painful osteophyte on thermography we see increased temperature activity when we compare this place with other side. Osteophytes metatarsophalangalis second and tertius lateri sinistri on X-ray and also on sonography we can see the ossificates, and in the site of painful ossificates we can see on thermography increased temperature activity. Bursa medialis metatarsophalangalis primi dextri. This is MRI finding of the bursa and sonography finding of field bursa. And on thermography over the field bursa on the right side, when we compare it with contralateral side, we see that the temperature is increased. Neoarthrosis between the heads of metatarsals second and tertius on the left side. we see this neuroarthrosis on X-ray, and on sonography we can see that the neuroarthrosis is filled with hypoalcoholic hydrops. And on the site of this neuroarthrosis, which is here, we can see increased temperature activity, which lead to painful. Bursa plantaris metatarsofalangalis, primi lateri dextri, and osteophyte. This osteophyte we can see here on X-ray, and feeling the bursa is plantarly above the tendon of flexor hallucis longus. Here we can see bursa longitudinally, transversally, and on thermography, we see that the bursa has increased temperature activity. Luxatio metatarsofalangalis quarti lateri sinistri. On X-ray and also on sonography, we see luxatio of this joint, hypoechoic feeling, and on sonography we can see also the detachment of insertion of the capsule of this joint. And on thermography, on the side of the metatarsofalangalis quarti, we can see increased temperature activity when we compare this place with contralateral side. Fractura ossis sesamoideae lateri dextri on X-ray and also on sonography, we can see this fracture site. And when we see thermography, here we can see increased temperature activity at the plantarly at the site of fractured sesamoideum. Total endoprosthesis metatarsofalangalis primi lateri dextri. Sonography finding looks normal, but the total endoprosthesis is complicated with inflammation, which could show on thermography, where we can see increased temperature activity. Conclusion: the results of our retrospective study of ankle and foot pain findings show that in 81% of cases there is a change in temperature activity in the ankle joint and foot area. Most sonographic findings of pain syndromes are of extra-articular origin. The combination of physical examination and thermographic examination with sonographic examination has better diagnostic accuracy than these examinations allows us to select targeted and individually tailored treatments. Thank you for your attention. Screen sharing is stopped. Is closed?
Marcus, I don't know why. Yeah. I guess that Marcus was trying to talk to you, but I don't know why we cannot hear you, Marcus. So maybe you need to change some configuration on your sound now. Now it's okay.
Okay. Wow, amazing, Gabriel. So, all times. See here.
Yes. Now I am
shoulder.
I can send you also the other books. Now I am completing the last book in this series of these findings of ankle joint and foot. When it will be ready, it would be honor for me to send it to you.
If you can find this on the internet or contact with Gabriel to buy this, because he has all in an atlas specifically for many of joints, the main. So he has a truly impressive material, well documented, and you're currently using point of care and bedside style approach, the camera very close to the problem, looking what's happened there. And it's exactly this close range image that allows the fantastic diagnosis and significantly improves the quality of your results. And everything is documented, the X-ray, MRI, ultrasound, So that's what I was tell my students and saying today, get close to the patient. Sure, we have full body protocol, different image, but don't forget the close image of patient to get the main information. It doesn't matter what resolution your camera has, but if you are close, you achieve better outcomes and more accurate diagnosis. I have some questions here. So you can use the hotspot box to locate the hottest point in the area of interest, especially where inflammation is suspected, and perform thermally guided palpation. Do you palpate the structure based on the real-time infrared image to assist in your clinical assessment? Do you use the image on that moment in real time?
Yes, I understand. But when I make thermography, no, when patient come to our department, first I take anamnesis and then I prepare him to thermography. And before thermography, I don't touch him. It is due to that I cannot influence the results of thermography.
Before,
And,
yeah, but after, when
the
you're looking, you know there's something wrong. You go on that direction with the hands and do the.
I touch the patient after making thermography, before making sonography and other imaging methods. But when I use, because I use thermography as a first tool, the purpose of that is that I don't want influence the image by my touching.
Yes.
And
sure.
After thermography, I examine patient also musculoskeletal and clinical, and after that I also touch the painful side.
Many times, do you receive the clinical cases all read with X-rays and other exams, writing reports, and then you perform the thermography afterward?
No, it's that the patient to our department is sent from other departments, and mostly patient has with him X-ray and MRI, and we filled these images with thermography and sonography. Great. It is our goal to complete the imaging methods with these methods, with thermography and sonography. It's the goal of our workplace.
Great. So I understand the infrared is the first line exam for you. The first line before to touch, before to do the ultrasound. So patient comes and you do the image. You do only the local image, the bedside image, first line, and after you do the ultrasound, palpate, and continue X-rays and MRI.
Before the ultrasound, I could examine him also clinically and musculoskeletal. Before the ultrasound, I can touch him, but before the thermography, it is not good because I could influence the results of thermography.
Yes, we know that. We understand. And when you do the image, infrared image, do you have idea, you suspect, it must be a tendinitis or bursitis or a fracture? Do you have this idea when you get the image before to do the ultrasound, X-ray, the other one. You feel this is possible for you?
No, the truth is that the patients are sent to our department when the course isn't right, when isn't normal, that treatment period is long, and therefore our colleagues sent these complicated patients to our department.
My question is different, it's a little different. When you do the image, the infrared image, do you know or do you feel what exactly have on this patient based on image? So you have it must be a fracture, it must be a liquid. I know that is not the final diagnosis.
Yes,
but do you have this experience to say, oh, there's really something wrong or a fracture? I will do the ultrasound.
Yes, I understand. But using only the thermography, we cannot know if there is fracture or heat drops or ossificate. But it's for us a very important indicator that in this place is something wrong.
Yeah, the prognosis, bad prognosis. You see, bad prognosis here.
For example, as I show you the surgical treated tendon Achilleus, which should be okay, but the patient still feel pain, and thermography showed us increased temperature activity, and then we see on it with other imaging methods, and it was found, and these methods found that it is not good healing, that is complicated healing, and in this case, I think had to be made a reoperation.
Okay.
And it is a very, very important indicator for us.
Okay, we have time here, don't worry, but I have some more questions. Monitoring, follow-up images, follow-up. Do you do the images after the treatment to compare, to see? Yes. Most of the time, in my experience, the patients go back to work, but the images are not so totally symmetrical yet. It's the same for you?
We have in plan in all patients, in every patient who we examine to make after the treatment the control image, thermography image. But it's not only on us. It's also on the patient if he calm, and also on the colleagues if they send him. But also in these cases which I show you, we have in maybe half of patients control thermographic images, but this presentation was only about diagnosis, income diagnosis, and therefore I didn't give the control images. But it is not problem. I have stored also the control images.
Okay, I will open for more questions here for the other, but the last one, because it's amazing. You have a great. Do you do report for these patients? For example, do you give a ultrasound report with infrared together, combine it? Do you do separated or in one? All in one. Yes, it's much better.
I give him reports in one paper.
Great.
All report also from thermography and also from sonography.
Oh, nice. question. Go ahead, Ken. Sorry, I interrupted you.
No, not at all. Actually, a lot of my questions were getting answered during the course of the conversation. Wonderful presentation. Thank you so much for sharing it. I wanted to ask you, how much are you using the thermogram to target areas to evaluate with the ultrasound versus just using the patient's symptomatology? Are you noticing that the thermogram fine-tunes how exactly what part of the structure you're looking at, or are you just doing the thermogram of the general area and then the ultrasound of the general area?
When I make thermography, I make this painful part the whole, from anterior, posterior, medial, lateral, plantar. In this presentation, I didn't show all this projection, but in real, I do all projection in thermography and also in sonography, because in many times the patient isn't able to tell us where exactly he feels the pain. He many times feel pain in all food, and we must find the exact point which causes him the pain.
Yeah, great. Thank you.
Not at all.
Thank you. And as you're monitoring with the thermography, you were mentioning this a little bit before. You use the patient's symptoms as a guide to see how well they're healing. You're probably doing different examinations on them. What's the role of the thermogram in terms of assessing overall healing of the injury?
No, the goal of thermogram is to differentiate between symptoms of pain, because the pain should be inflammatory and should be sympathetically and should be not independent on sympathetically and on inflammation. And we have to know which kind of pain it is, because after that we use the treatment. When it is inflammatory pain, the temperature is increased. We use the anti-inflammatory treatment, mostly local, not using the drugs. And when it is increased temperature activity, as we also saw in this presentation, that some less part of patients had increased temperature activity, then it is not. We don't use anti-inflammatory drugs because this anti-inflammatory treatment shouldn't have any sense. We use then we try to find the cause of the sympathetically maintained pain. What caused the increased sympathetic activity? And when we find the cause of this kind of pain, when we treat it, it should be blockage, for example. Blockage also cause increased sympathetic activity and hypothermia. And when we release the blockage, sympathetic system isn't activated, and temperature will be normal. And The most difficult part of findings and type of pain is not non-inflammatory sympathetically independent pain. In that case, we see normal thermal pattern and patient feel pain. This case isn't a huge amount, but these patients make us the huge problem because there is the most difficult to find the cause of the pain.
Very good. Saad,
great. Thank you.
Thank you. Saad, go ahead.
Thank you, Dr. Briosky. First, I would like to thank Dr. Gabrhel for the interesting presentation. And as well, I wanted to ask you, Dr. Gabrhel, regarding when do you think the patients should have perform X-ray or MRIs when the temperature is beyond or above the normative data in 0.5, 1 degree? How much do you think it's the average that we need to make X-rays or MRIs, you think, to find more issues?
Pardon? Yes. I didn't understand, and my daughter will be help. No, it's not. In our department, we examine and treat the patient which were not treated successfully with normal stay. And therefore, most of the patients come to our department with X-ray and MRI. They had done these imaging methods before they come to our department, and we filled these imaging methods with our methods.
Okay, so you correlate the findings, the pathophysiological findings in the MRIs and X-rays with the thermography to apply to functionality.
Yes, then we all these findings compare and try to find the main result of problem and find the way for successful treating.
Okay, thank you very much. I appreciate it. Thank you.
Not at all. You are welcome.
Most of time, I guess you have a mix of orthopedic problems, joints, tendons, with radicular, but all the radicular problems mixing on the image. I saw many cases that you have L5 problems, but the main cause was the ankle and the toes. But is it very common for you to see this mix? And it's a problem, or don't it's not a problem?
Yes, we follow also this problem, and we have also patients with radicular syndromes and with vertebral problems. And I have also one group and one little study of completion MRI findings with sonography with thermographic findings, and we also try to follow the temperature in thermotones in lower limbs, upper limbs, and according the change of temperature in the appropriate thermotones, we stanovíme, we stage the prognosis. If in the thermotones isn't changed temperature much or isn't changed, the prognosis is better. But if the temperature in appropriate thermotones in the limbs is high, the prognosis is worse. It follow we for long time, many years, and about this problem we have also presentation of vertebrological symposium last year, where we showed that many patients are relieved in their pain after solved the inflammation, after normalized the thermal pattern, and also napriek tomu, že despite they didn't have change in, for example, extrusion, protrusion. That means that on MRI the finding was never the same, but thermography finding normalized, and the pain in patients relieved. And this is also the why we need the thermography in vertebral problems, in spine problems.
Many of your cases are acute cases.
Yes.
1 week, 1 month. When you have cold images on this situation, not chronic, in acute, it means that is a worst prognosis for these cases. Do you have this experience to say, oh, here's more complex? It's not just a fracture. Maybe, as you explain, a sympathetic pain to mixing on acute phase. Do you have this? Do you see on your experience that they have much more time to recovery than when you have only hot spots or increased temperature? Cold ones situations are worst. Is it for you?
Yes. Cold temperature pattern is mostly was solving. The treating is mostly longer than in increased temperature when we see increased temperature activity, because it's mostly this problem to find the source of the increased sympathetic activity.
Okay.
And
does anyone have any questions? Marwan, if you want to do questions about CRPS, Sergio, Adrian, no? Gabriel, Sarah, Kubishek.
I would like to congratulate you for your excellent presentation. It was amazing. I hope that you share with us the link in order to be able to have a look at your books. I'm from Spain, so also Europe as you. So it was really amazing. Yeah, if you could share the books, because I was trying to find them on internet, but I was not able to. And also, if you could share the link about the symposium you already mentioned, will be more than honored to visit it.
Thank you very much.
And thanks to your daughter as well for the translation, for helping.
Yeah, thank you. Any question? No? It's okay. Thank you, Gabriel, one more time. Always is spectacular amazing images, and congratulations for all your work documentation to help so many people with infrared and your knowledge in musculoskeletal. Thanks so much. Have a good day.
Thank you also for inviting me, and all good.
And in the name of American Academy of Ophthalmology, we thank you and congratulations. I send you a certificate of this to take part with us. And feel free to take part on our Saturdays medical minutes every Saturday in the same time, the same link, but with different speakers. Thanks so much. Have a good day. Thank you.
Have a good time, and thank you very much.
Congratulations.
Congratulations.
Thank you.
Thank you very much.